Hi, my name is Frazer Tessema, and I'm here to talk about how the pricing of soon-to-emerge sickle cell disease gene therapies may threaten to exacerbate health disparities in America today. I'm a first-year medical student at the University of Chicago, and before that, I worked for 3 years at Harvard studying the regulation of pharmaceuticals. Sickle cell disease gene therapies may cure a disease that has long been uncurable. There are two ways in which it would be used as a viral vector or as a CRISPR-Cas9 technology in which stem cells are genetically modified and reintroduced into patients to cure the disease. There are some standards of care like hydroxyurea that have been long time used for chronic use. And there are also two recent drug approvals that also can help with chronic use. Um, Although these gene therapies may be curative, they are extremely expensive at $1 million dollars or more for one-time use. Um, some have justified this price by arguing that sickle cell disease patients cost about $1 million dollars or more for a lifetime of care. Also, there are precedents with the disease beta thalassemia, where a gene therapy was launched in Europe in 2019 for $1.8 million dollars under similar logic. Also, orphan drugs have been increasing in price generally, and CAR T gene therapy pricing, which started in 2017, has also influenced these inflated prices. Uh, Although these considerations are important, there are other considerations that are not being talked about. And that is why I'm here today to talk about those considerations. One is the equity consideration. So sickle cell disease has a large disparity in research in terms of federal funding, foundation expenditures, research articles, and FDA drug approvals as compared to diseases of similar prevalence. And also the NIH contribution to the gene therapy development, not just in terms of NIH funding, but also in terms of literal development of the science, which happened at trial sites in Bethesda, Maryland. Um, Also, an important consideration is the demographics of sickle cell disease. If we were trying to correct inequities through the pricing of this drug, it is important to consider how Black Americans are predominantly affected by sickle cell disease. And also, it's important to consider how it would be the largest population ever eligible for a gene therapy to date at about 100,000 people. And also that there are major considerations of insurance coverage, which could impact how we pay for and are able to give access to these drugs. Medicaid covers about 55% of all sickle cell disease patients, and there are also major racial disparities in access to private health insurance that could impact how patients are able to afford medications. So I wanted to give you an example of how this would affect a state. This is Illinois, where about 2,000 patients have sickle cell disease and are covered by Medicaid. If a gene therapy came out that cost about $1 million, that would mean about $2 billion in spending, or more than 2.2 times the entire Medicaid budget for the state, which would be simply unaffordable. Even if, for example, 5% or fewer patients were covered per year, that would still be an incredible amount off the budget, and one can imagine really impacting what Medicaid is able to afford for its patients. Um, this is reminiscent of a case from 5 years ago or so, Sovaldi or Savostivir, the hepatitis C cure, which also came out and also was priced at a high price, $84,000 per curative treatment. And as that happened, state Medicaid programs and prisons really struggled to afford the medications, and it really deeply impacted how patients were able to get care and exacerbated racial health disparities and who was able to access care. From that Sovaldi episode, there were some lessons we learned and some payment strategies that were developed. Perhaps the most memorable and innovative was the so-called Netflix model, in which fixed monthly payments for unlimited treatment were used by some state Medicaids, for example, in Louisiana, to afford Hep C drugs for their patients. Um, in 2019, US Senator Bill Cassidy from Louisiana suggested that when sickle cell disease gene therapies emerged, that we could similarly use the so-called fixed payment Netflix model. There were also considerations that Cassidy brought up, who is a gastroenterologist. He suggested that we could create private payer funds that could be used to somehow pay for curative treatments. He also suggested that perhaps the federal government could be a main payer and absolve private insurers of what they're able to pay. And also the creation of an installments by age plan in which the price of a therapy was divided by life expectancy of a therapy to arrive at an annual cost per year of what a patient's insurance could be expected to pay for that drug for that patient. Um, these are innovative and thoughtful, and we're appreciative that Cassie thought of them, but we think that there are some problems with some of these policy proposals. For example, the installments plan would burden people with crippling debt for years and decades. And so we also wanted alternate models to be considered. For example, a federal review board for drugs priced greater than 500,000. We also would encourage the federal government to cite its NIH funding and research of sickle cell disease to lower the amount that is paid to avoid so-called paying twice for both the NIH research and later the Medicaid payment. We also think equity should be reconsidered in how it's used to determine drug price. For example, in 2019, when sickle cell disease treatments were coming out, people argued that those prices should be high because it's a way to incentivize development for a population that has been ignored. But we also think that it's important to consider how those populations have been ignored, and that a way to make sure that they get access and do have equitable treatment is to make those drugs affordable. And so we would argue that equity is actually a reason to lower the price of the drug.